Hello, and welcome to another episode of AUA University Podcast, where we explore important and evolving topics that shape urologic practice through expert discussion and evidence-based insight. I'm your host, Dr. Mark Gonzalgo, Professor of Urology at the University of Miami and Chair of the AUA Office of Education. Today's episode focuses on recurrent uncomplicated urinary tract infections in women, a highly prevalent and often frustrating condition for both patients and clinicians. We'll discuss best practices in diagnosis, management, and prevention with a focus on the most recent AUA guideline recommendations and the evolving landscape of antibiotic stewardship and non-antibiotic prophylaxis. I'm delighted to be joined today by two leading experts in the field. First, Dr. Lenore Ackerman, Associate Professor of Urology and Obstetrics and Gynecology at UCLA. Dr. Ackerman's research focuses on the urinary microbiome and how understanding host microbe interactions can improve diagnosis and treatment of lower urinary tract symptoms. She currently chairs the AUA Guidelines Committee for the Diagnosis and Management of Uncomplicated Recurrent UTI in Women and is an internationally recognized authority on this topic, having served on multiple clinical society guidance committees. Dr. Ackerman was the 2023 recipient of the Zimskind Award from SUFU. Also joining us is Dr. Melissa Kaufman, Professor and Patricia N. Rhodes Hart Endowed Chair of Urologic Surgery and Chief of the Division of Reconstructive Urology and Pelvic Health at Vanderbilt Medical Center. Dr. Kaufman has made outstanding contributions through her work on multiple AUA committees and serves as an associate editor for the Journal of Urology and for Neurourology and Urodynamics. She is past president of the Society of Women in Urology, a previous recipient of the Zimskind Award from SUFU, and the 2025 recipient of the AUA Distinguished Mid-Career Award. Welcome, Dr. Ackerman and Dr. Kaufman.
Well, we appreciate that kind introduction, Dr. Gonzalgo, and we additionally want to thank our podcast audience for their engagement and interest in the topic of treatment of recurrent urinary tract infections, which really, as you mentioned, is an incredibly impactful condition for both the individual and really our entire healthcare infrastructure.
To begin, let's review the fundamentals of evaluating a woman with recurrent uncomplicated UTI. Dr. Kaufman, when approaching these patients, how do you structure your evaluation? And specifically, what is the role of the pelvic exam, urine culture, and symptom documentation?
Thank you for that question. To set some context for the discussion, let me just remind everyone the index patient population we're addressing in this guideline and in this podcast. These are women with localized cystitis that's really restricted to the lower urinary tract. Patients with complicating anatomic or functional factors or systemic involvement are managed differently. And although there can be overlap with the strategies, that's really not the primary target population for these guidelines. Additionally, there are multiple definitions of recurrent urinary tract infection, but this guideline supports the most commonly utilized definition of 2 episodes of bacterial cystitis within a 6-month period within the preceding year. So we're going to discuss in greater detail in this session, like diagnostic strategies to determine the presence of urinary tract infection. But acute cystitis really implies new onset symptoms, like dysuria, which is really central to the diagnosis, in conjunction with variable degrees of other types of storage symptoms like urinary urgency, frequency, hematuria, or new or worsening incontinence. So to address your question directly with regards to recurrent urinary tract infection evaluation, it's of course a clinical principle to perform a history focused on the patient's urinary symptoms associated with the urinary tract infection. You need to understand details of any prior surgical interventions, their baseline genitourinary symptoms, even bowel symptoms that can be quite useful in discerning urinary infections from other comorbid or really confounding urinary conditions. Symptoms that the patient considers related to urinary tract infection and the relationship to other triggers, as well as treatments that have been previously prescribed, need to be elucidated. And it is recommended, as you mentioned, that the initial presentation include a pelvic exam. This exam can be incredibly helpful to determine other comorbid conditions which may be significant contributors, things like vaginal atrophy from genitourinary syndrome of menopause, even urethral diverticulum, or pelvic organ prolapse. Now, one of the primary modifications of the latest guideline amendment is really how we think of urinary tract infection and symptomatic acute cystitis with regards to our diagnostic strategies. There is a very significant negative predictive value for negative urinalysis, meaning a UA without nitrites, without white blood cells. This turns out to be useful at ruling out acute cystitis with a very low risk of progression to things like bacteremia. But unfortunately, as we're all aware, positive urinalysis with nitrites may indicate what we now appreciate as a normal commensal complement to the bladder. So as our conceptualization of this urinary microbiome evolves, we understand that it's not a sterile environment. There's many symbiotic organisms that are part of our normal physiology. And Dr. Ackerman will discuss later how overutilization of antimicrobials can lead to a systemic dysbiosis and disruption of this really careful homeostasis. But when we evaluate the urinalysis to make a diagnosis of urinary tract infection, we should document not just the presence of uropathogenic bacteria with culture. These are specifically associated with symptomatic episodes, but also document evidence of inflammation or pyuria, which is measured on microscopic analysis of greater than 5 white blood cells per high-powered field. Now, the diagnostic threshold for colony counts on standard culture continues to be a topic of debate, and we will say that it needs to be documented that there are positive urine cultures at the presence of symptoms along with pyuria or evidence of inflammation. And the guideline amendment also very thoughtfully addresses the fact that contamination of clean catch specimens with skin and vaginal bacteria is very common and can result in very high rates of suboptimal or really unnecessary treatments. If there's a question regarding contamination of the specimen, the clinician should really consider obtaining a catheterized specimen for the most accurate sampling.
Great. So a structured approach, I guess, confirming symptoms, as you pointed out, ensuring accurate specimen collection, and certainly ruling out other pelvic or anatomic factors forms a foundation for proper management. Moving to diagnostic strategies, Dr. Ackerman, your work really has been pivotal in understanding the urinary microbiome and advancing diagnostic strategies. Can you elaborate on some of the limitations of traditional urine culture and when molecular techniques like next generation sequencing or PCR might be of value?
Absolutely. So I think one of the things that probably most urologists are familiar with is a growing frustration on the part of our patients, and frankly, even amongst ourselves with urine cultures and how it can help us diagnose these patients and do better to prevent future episodes of UTIs in patients with recurrences. And I think we draw from those urine cultures the fact that they are slow. So it often can take, at best it's a day or two, but often in our system, it can be 3 or 4 days before we're getting a speciated urine culture back with susceptibilities. And it is also relatively insensitive. The urine culture is best utilized for detecting things like E. coli, which commonly is thought to be the most common organism that causes urinary tract infections. But frankly, because urine cultures actually grow things like E. coli much better than other types of bacteria, there is a sort of question about whether that's really true or not, since it doesn't detect other types of bacteria quite as well. And then lastly, it's quite error prone, frankly. It's prone to false negatives and false positives. And what, lots of urologists can probably describe that scenario where you have that completely negative urinalysis and a positive urine culture. And you think to yourself, why does this happen? Well, there are a lot of reasons why it happens, and some of which have to do with urine culture itself, and some of which have to do with our not using it appropriately as a tool. So one other thing that can happen quite frequently in urine culture is that mishandling of specimens. And what that means is once a urine is, deposited in a specimen tube, if that sits out for any significant amount of time, you can have overgrowth of bacteria that really are not actually derived from the bladder itself. They may be small contaminants and grow way out of proportion to what is actually there in the urine to begin with. And you can have contaminants from just the environment around that can grow and provide these false positives. And then again, it doesn't necessarily always detect or facilitate the growth of some of the more fastidious organisms. So we may miss a lot of things. And so when you look at some of the largest sort of retrospective analyses of urine cultures in patients presenting with symptoms that are consistent with UTI, those are only positive about half of the time, which leaves us with a couple of possible conclusions. One is that urine culture is right always, and 50% of those patients didn't have an infection, or that urine culture isn't really all that good at figuring out whether somebody has an infection or not. And I honestly don't know which of those two answers it really is, but either way, we have to think about it a little bit differently. A lot of people have asked me, in looking at the update to the guidelines, so what do we go to try to be sure that we can diagnose this correctly? And the answer is dissatisfying to many people. It is not a happy answer, but the answer is there is no test that's going to give you anything better than your clinical judgment about whether that patient in front of you has an infection or not. And we need to think of these tools like urine culture rather as things that help us figure out whether the patient has a UTI or not, but more as, if I really strongly have a belief that they probably have an infection, they're going to help me figure out what to treat. And so I think that is a reframing about how we think about bacterial identification that I would like to see kind of seep into our ways of approaching UTIs, that we have to take into all of that consideration, the urinalysis, the patient's clinical presentation, again, what Dr. Kaufman just described about, you have to have that acute onset symptoms that are consistent with a UTI. So not vaginal discharge and discomfort, but urinary, burning with peeing and new urgency and frequency. You have to have a urinalysis that demonstrates that inflammation. And probably you want to be able to identify bacteria, and all of those things, if they're present, maybe that helps you come into a decision that you're pretty confident this patient has an infection and that you should treat them. And then in that context, whatever form of microbial identification you use should be used to say, okay, what am I going to give them now to make them feel better? And then you can use that to guide your antibiotic choices or your conservative measures that you choose, whichever way you decide to go. And so that ties into this idea of how do we use these newer technologies like next generation sequencing or PCR or whatever ways we want to think about detecting bacteria. There may be things that come down the line later that are different approaches, but whatever they are, I think we cannot defer our judgment to the test, because we know that urine culture may not actually be very good at deciding whether somebody has an infection or not. And next generation sequencing, PCR, and these molecular diagnostics also have their flaws. So let's talk a little bit about what those techniques are and what we can use them for. And so both next generation sequencing and PCR, which people will commonly know and probably encounter in their clinical practice with a bunch of different brand names, but those tests will detect the components of bacteria. So these two tests tend to detect the actual DNA that's associated with bacteria, but there are other approaches too. And those components of bacteria are detected with much more rapid diagnostics that can either sequence those directly or then amplify them and then recognize those sequenced products. And by using those non-culture directed tests, they are much better at providing a wider range of recognition of bacteria. So there's that strength that there's a greater range of bacteria that can be identified on those tests. And in fact, some of the commercial tests also identify some yeasts and other fungi as well. So there is greater sensitivity, and as well, they're much more capable of detecting small amounts of bacteria, and that is both a plus and a minus. So that sensitivity is great, maybe fewer false negatives, but what it also means is that you're going to detect bacteria in almost everyone. And so we cannot think about these as tests to tell us infection, no infection. They're probably going to tell us that there's bacteria there in almost everybody. What we need to be able to use them for is to say, okay, if that's the bacteria that's there, and I'm very convinced this patient has an infection, I can use this test to decide what I want to treat. There's also the fact, and I mentioned this briefly, is that these tests have the potential for much faster turnaround times than urine culture, which again is possibly beneficial. There's a lot of concern from which I think is a reasonable concern, that if these tests can detect bacteria in almost everybody, isn't there this dramatic, terrible potential for overuse of these tests, and then overdiagnosis and overtreatment and just massive antibiotic overuse? And that is a very real fear. And I think that is why there is a lot of caution when thinking about how to use these tests. But it's important to kind of take a step back and say, it's not the test's fault. We have to use the test appropriately. And so that faster turnaround time actually could be a boon if we think about it in the longer term, so that instead of, say, the patient coming into your office, they are miserable, they hate life at the moment, they're curled up in a ball, they're not able to go to work, they're not able to participate in life. We don't want them to sit in that misery for those 4 days till the speciation and the cultures and the sensitivities all come back. We want to be able to give them something. So we're going to give them empiric antibiotics. But at least a third of empiric antibiotics are wrong. And so we know that we're already going to be contributing to more antibiotic resistance and overuse of antibiotics that were unnecessary. And then they're going to end up getting more antibiotics total. And all of that's not great for patients. So if you could get a test result back in a day or less than a day, in a couple of hours, wouldn't that be better for the patient? Again, talking about a patient that you have a strong suspicion has an infection and you were going to treat him anyway, wouldn't it be better to be able to treat them in a targeted way that's actually going to treat whatever's growing inside them and causing this infection? So that rapidity of these kinds of tests could be a great boon, but there is that extreme amount of caution that we need to think about, in that it only works in our favor. It only helps us do better for UTI management if we're thoughtful about how we use it. And so I think the take-home message from all of this is that urine culture has been our historical gold standard, but we have to listen to our patients and to ourselves and understand that it is an error-prone tool, and that to continue to cling to the idea that urine culture is the ultimate arbiter about whether somebody has an infection is to do our patients and ourselves a disservice. We need to shift away from a culture-centric diagnostic paradigm to one that is based on our clinical reasoning, that is supported by the laboratory data, supported by our assessment of patient symptoms, and reflects our modern understanding of the urinary microbiome and antibiotic stewardship principles. And if we take all of that together, I think there's a point where we can say all of these tests have flaws, all of them have benefits, all of them do something to inform us. So I'm less concerned about maybe which one is used, as long as we're doing our best to try to identify what is going on and identify, which antibiotics we need to be using, but also using that information, taking into consideration each one of those tests' limitations, taking into consideration the patient that's sitting in front of us, and really trying to put all of that together to do the best that we can for prescribing and treating those patients moving forward.
Yeah, that's great. And, these are all very important points. And I think it's clear that while molecular tools can help to expand our understanding of urinary microbial diversity, they really should be applied, as you pointed out, judiciously, and more importantly, interpreted in the context of the overall clinical picture of the patients that we treat.
Absolutely. So that's, I think, the take-home message is that no test can replace our judgment, and all we can do is use them as tools. And so I will take a step back and just say, that the guideline is very clear to say that urine culture still does remain the gold standard. But what I would also say is that it actually would, I think that we would all do better if we utilized, to sort of go back to Dr. Kaufman's point, urinalysis with a reflex to culture. And that would be my personal test of choice, because it incorporates the idea that you need to have that inflammation present. And then you reduce the rates with which you get that culture back that's positive, and the urinalysis is negative, and you have to sit there and explain to the patient why you're not going to treat that positive culture because it's not consistent with their clinical picture. If we just get rid of that and we actually do this sort of graded thing where you start with culture, then I think you actually see a much better stewardship. And that's been proven out in the literature, that we can actually reduce the number of antibiotics given to a fifth of what is actually given if we employ techniques like urinalysis with reflex to culture.
Great. Dr. Kaufman, many patients seek ways to prevent recurrent infections without continuous antibiotic use. What's the current evidence for non-antibiotic prophylaxis strategies?
Yes, as Dr. Ackerman mentioned, antimicrobial stewardship, which we'll discuss a little bit in further detail, is really a growing concern. So there's antibiotic overutilization and resistance, and this guideline very thoughtfully addresses optimization of non-antibiotic prophylaxis for the recurrent urinary tract infection patient. Several of the guideline statements that emerged due to new evidence in the literature, which is really a testament to continued interest and impact for research in this area. But one of the foremost new statements of great utility is actually a behavioral modification. Women with recurrent urinary infections with low water intake may be offered increased water intake for prophylaxis. There's some modest data that actually suggests this is such a low risk and effective method that really reduces their risk of recurrence. Typically I encourage hydration above 1.5 liters a day to decrease UTIs. Now, granted, for women who have comorbid conditions like overactive bladder, this can be challenging, may require multimodal treatment, but overall, conservative measures to temporize symptoms during natural clearance of microbial overgrowth is a very reasonable strategy for many women. And let me just step back for a second to discuss why some of the other prophylactic measures, such as cranberry and D-mannose, are proposed. We want to lay a little bit of context as why these are theoretically effective against our most common uropathogenic E. coli. Now, binding to human cells, to bladder urothelium for E. coli is mediated by projections on the cell surface called fimbriae. And the distal portion of these fimbriae has mannose receptor. So blocking this receptor with D-mannose or the proanthocyanidins of cranberry really decreases the capacity for bacterial binding and colonization of the urothelium. And there's been a number of systematic reviews comparing cranberry and placebo, and they are a lot of different formulations of cranberry, but they favored use of cranberry for UTI prophylaxis. And most healthcare providers, utilize contemporary formulations that have 36 milligrams of bioavailable proanthocyanidins for prophylaxis. Now, clinicians can also offer methenamine hippurate for prophylaxis. Methenamine is a very interesting compound. It cleaves into bacteriostatic agents, formaldehyde and ammonia, and decreases the bacterial load then in the bladder. And traditionally, we've combined this with vitamin C to acidify urine. However, contemporary data really doesn't support pH modifiers to enhance the methenamine efficacy. Now, generally, methenamine should be discontinued if antibiotics are necessary for treatment. And as mentioned, like many clinicians do utilize D-mannose for UTI prophylaxis. Contemporary evidence really does not support use of D-mannose alone for prophylaxis. However, as mentioned before, in general, the risk-benefit profile for this agent is very favorable, and patients who are actually benefiting from D-mannose shouldn't be encouraged to discontinue just because our evidence base suggests that on a population level, it may not be as beneficial. Because for an individual, it may be something that is helping them modify their own microbiome to decrease their risk of recurrence. The guidelines also addressed a number of other prophylactic agents, including probiotics and supplements, some intravesical agents, immunotherapies, and there was really no compelling data to support use of any of these other things. However, there is very strong data that in perimenopausal and postmenopausal women with recurrent urinary tract infections, low dose vaginal estrogen can reduce the risk of future urinary infections. It's outlined as well in our genitourinary syndrome of menopause guidelines that vaginal estrogen is standard of care treatment for symptoms of GSM, like dysuria, dyspareunia, vaginal dryness. And of course, there's select patient populations that require a higher level of shared decision-making with use of vaginal estrogen, but it should always be considered in perimenopausal and postmenopausal women with recurrent infections. Which kind of additionally raises the topic of other potential concomitant urologic pathologies, particularly in the presence of asymptomatic bacteriuria. Lower urinary tract symptoms with predominant storage dysfunction can be very difficult to delineate. There's a diverse number of conditions that should be investigated in this population, like interstitial cystitis, pelvic floor myofascial pain, or overactive bladder, really, which mimic symptoms of UTI and can confound the diagnosis.
So again, quite a complex area. It can be in a combination of what you mentioned between targeted and behavioral, as well as pharmacologic prophylaxis anchored in patient-specific risk factors may remain perhaps one of the most rational approaches for treatment of this type of condition.
Absolutely. To begin with these types of strategies that reduce our utilization of antimicrobials is oftentimes the most prudent way to begin to approach the patient with the recurrent urinary tract infection.
Finally, let's address antibiotic therapy. Dr. Ackerman, how should clinicians approach antibiotic selection and duration while promoting stewardship?
That's such a great question. And it's such a challenge, I think, for many of us. And there is an attitude, I think, that we often sort of take for granted in the medical community that, like, if somebody comes in and is having really bothersome symptoms, well, let's just treat them. What's the harm, right? And I think that we have reached a tipping point in the global antibiotic stewardship, quest or whatever, that we cannot think that way anymore. And antibiotic stewardship must be the responsibility of all of us, or there are consequences that could be, again, such an important and profound impact on all of the population. So antibiotic overuse and misuse is rising incredibly, and managing UTIs and recurrent UTIs is part of that pattern. Antibiotics administered for UTIs are one of the most common indications out there. It's, I think, the number 3 indication for antibiotics in the world. And it may be more, sometimes we don't necessarily capture all of that, but all of those antibiotics contribute to rising antibiotic resistance. It's important to take a step back and think that when someone presents with symptoms of localized cystitis, and I think that's another concept I'd like to come back and stress, which is that there is a movement, I think, internationally, not just within the AUA, but internationally, that's also now endorsed by the Infectious Disease Society of America, that we need to think about UTIs differently. And we used to think about them in terms of uncomplicated and complicated. And I think people have found that really confusing, because the distinctions of what makes something complicated. For example, all men are thought to be complicated. All pregnant women are complicated. Anybody with a catheter is complicated. And so there's this huge amount of people that fall into this category of complicating factors that we tend to treat as if they have pyelonephritis rather than as if they have a localized infection. And so there's a movement towards going away from that concept and instead thinking about this as localized infection versus systemic infection. And so if somebody really has only localized symptoms and signs, the likelihood of them progressing to a systemic infection is very low. And most of the studies show almost no, if any, difference between patients' progression to a more systemic infection with or without antibiotics. That may imply that, like, by the time they're symptomatic, whatever's going to happen is going to happen, and it's too late at that point. But whatever the reason is, antibiotics, we tend to think of it as this, oh, I better make sure this patient is okay and give them antibiotics to prevent this complication. And that's really not based in actual data. Most of the data that we have shows us that localized infections are actually very rare to progress to something like pyelonephritis. And if left untreated, most will actually self-resolve. Now, that is no happy note to a woman who's really experiencing pretty terrible symptoms. But it is something that we must all keep in mind when we have that patient where we're kind of like, we're on the fence, or we're waiting for more data. And so I think that we have to take in this idea that as we, instead of, oh, what's the harm, in actually, there's a lot of harm. I need to be careful about who I'm doing. And I can be reassured by the fact that it's unlikely that waiting a day or getting more information is going to result in a negative consequence for the patient. So overprescription of broad spectrum antibiotics is yet another aspect to this. So one of the other aspects to the guidelines is that when we're thinking about prescribing antibiotics, which again, not at all against that for a symptomatic woman for whom we're pretty convinced has a UTI, we want to try to minimize the broad spectruminess, if you will. So we want the narrowest spectrum drugs that we can safely give. And we want to use the shortest duration that is reasonable. And so there are guidelines, within the guidelines, there are recommendations. So sort of your first line agent should really be nitrofurantoin. If it's, if the bacteria is susceptible to it and the patient is not allergic to it, because it is the least likely to cause damage outside of the urinary tract. It is concentrated in the urinary tract. It does very little outside of the urinary tract. And so it's our most sort of focused therapy and has the fewest sort of systemic side effects with regards to the antibiotic resistance development and perturbation of the microbiome in other locations. And, moving up from there, there are other agents and sort of there's a hierarchy, but I think we have, a lot of patients come in and they say, oh, last time I had an infection, I got 14 days of Cipro. And you're like, you need to, in that moment, take your antibiotic stewardship hat and put that on and say, that's not the right thing to do in this situation. There is just so much evidence to show us that increasing the duration of antibiotics or the broad spectrum nature of an antibiotic is not going to help clear the infection any better. If you target that infection to a susceptibility that you got on a culture, 5 days of nitrofurantoin should be just as effective as Cipro for 14 days. But the consequences, those negative consequences, will be far greater, both to society and to that individual. So let's talk a little bit about what is collateral damage, because that's a term that's growing in frequency. The ID docs use that a lot. What does it mean? Well, it means not only the impact on the community by, increasing the possibility of antimicrobial resistance. It also means that there is a risk that as you destroy the natural microbiome, there are all of these other potential consequences. So these microbes that live with us within the body, they live in the vagina, they live in the gut, they live in the mouth. When those are destroyed by antibiotics, and of course, more of them will be destroyed, the broader spectrum the antibiotic, the longer the duration, the more that we place patients at risk for a number of different complications, not only antibiotic resistance, but antibiotic-associated diarrhea or other consequences. And then the possible emergence of secondary infections like Clostridium difficile, the promotion of resistance reservoirs in lots of different locations within that patient. So we're promoting not only systemic or global antimicrobial resistance, but antimicrobial resistance within the patient. And all of that. And then there are obviously secondary effects, like you can have thrush in the mouth or vaginal yeast infections that occur because you've destroyed those bacterial natural defenses to the patient against those infections. And then I want to mention something else that I think is kind of underplayed, and there isn't as hard evidence for this, but we are now beginning to recognize, now that we understand there's a microbiome in the body, that there are these bacterial communities, that the more that they're messed with, the more that we see lots of other comorbidities that we think are related to these perturbations in the microbiome. So we know that diabetes, for example, and poor glucose control within diabetes is related to the gut microbiome. And we've seen that antibiotic use, and the more antibiotic use, the more broad spectrum antibiotic use, is actually associated with higher risk of sort of access to disorders like anxiety and depression. And none of this is completely conclusive yet. A lot of it is association studies, but I think we should take a lot of that in, and above and beyond our responsibility to try to prevent antimicrobial resistance is our duty to actually do the best for the health of our patients. And I think that needs to be part of the balance as well. So if we realize that this risk of pyelonephritis is really not actually all that great, and the risk of these other things like brittle diabetes and depression and C. difficile colitis and post-antibiotic associated diarrhea is actually really real, maybe we can think with a little bit more discrimination about who we're going to hand those antibiotics off to. So antibiotic stewardship starts with diagnostic stewardship. So that is, I think, our most important thing that we need to keep in mind is, again, comes back to that idea of using our clinical judgment and interpreting those culture results. It comes back to really recognizing those symptoms and evaluating patients with every presentation, and really deciding, is this patient going to benefit from antibiotics? And so we talked a little bit about which ones to prescribe, and I've just spent a bunch of time talking about how maybe we need to be more careful and not prescribe them sometimes, but you don't want to leave a patient without support, right? So that comes back to, what else can we do for them? Well, there are actually a lot of supportive approaches that we can offer patients that do seem to have clinical benefit and can, if a patient desires it, get them through that awful phase where they're really symptomatic to the point where they actually can recover. And so those are things like, there's actually proven benefit to ibuprofen or sort of supportive analgesic care, phenazopyridine, which can also help a lot with the burning symptoms and pain associated with urination, increased hydration, and even things like, in the moment, D-mannose and cranberry seem to have some impact on curbing the course of an acute infection in addition to their role in prophylaxis. So if we think about all these things, then we come back to, well, how does a patient decide, do I want antibiotics or do I want to try these supportive measures? And a lot of that comes back to, we actually need to have that discussion with the patient. And so that means that when they get these infections, we cannot just rely, and this is hard for medicine, we don't get paid for this, but we have to do it. We have to have that conversation with the patient where we say, guess what? Your risk of pyelonephritis is not that great. Your risk with antibiotics is greater than you may realize. Do you really want antibiotics, or could we try these other things and see how they go? And actually, patients, when they get the information, when they learn about these things, are actually quite receptive to the idea that maybe we could try hydration and ibuprofen and pyridium for a day or two. And if it's miserable, they can take their antibiotic. But if they can get through, then we have actually spared them that damage that they may have incurred. And there's another couple reasons why sparing that damage may actually be really, really important. And one is that we talked about the risk of secondary infections like C. difficile. But there is actually, I think, some rising evidence to show that when we perturb the natural microbiome, we actually increase somebody's risk for a subsequent UTI. And so there may be something about giving a lot of antibiotics that actually reinforces the cycle of UTIs that are happening in these patients. And that becomes in itself part of the reason why these are recurrent, right? That we treat them, we destroy their natural defenses, we destroy the natural microbiome. And so that reduces their resistance to the subsequent infection. It enhances antibiotic resistance among the bacteria that remain, because we have also data that shows that antibiotics don't kill 100% of the bacteria that causes UTIs. So there's going to be some of those guys left over, and we just encourage them to get meaner. So this idea that we may be part of that perpetuation by doing a lot of intermittent and empiric antibiotic treatment, we have to realize that may be part of the whole thing, the whole sort of presentation. And that is what that also gets to, is that when somebody fights an infection, when they actually use supportive care or non-antibiotic ways of managing their infection, there may be, and this is just some data that seems to be coming out of the trials looking at a UTI vaccine, but they may actually be allowing their own immune system to gain the ability to fight these bacteria, and gaining that immunity that they would never have had if they treated it into oblivion with antibiotics. And so there may be another reason why trying to get people away from just empiric antibiotic use may actually be better for them in the longer term. So, that again is somewhat speculative. But let's put it this way: there's a UTI vaccine. It's not available in the US, but it does work. There are so many trials now showing that it reduces the rates of recurrent UTIs in women. And if it works, then immunity against urinary bacteria causing infections is real. So the immune system can develop that immunity on its own. It doesn't necessarily need the vaccine, but it does need the chance to develop that immunity. And so I think I just want to kind of leave that out there as being a bunch of reasons to, when you start to write that antibiotic prescription, to think twice and really make sure that it is something you've talked to the patient about. Because if you ask patients, they're afraid of the damage that antibiotics are doing. A lot of them are. They're not excited about needing them so much. They are looking for another solution. And so have that caution when you pull out that, I know nobody has prescription pads anymore, but when you pull out that epic, order form, whatever, think twice and just make sure that you're thinking about the right thing and not the easiest thing. So I think that ties in a little bit, and I'm sorry for going on for so long, but that ties in a little bit to what we were talking about in terms of prophylaxis. And that is that when we think about how to treat infections, I think one of the other things that comes up quite often is that there is not a strong recommendation, and there is not fantastic data to support the idea that prophylaxis is better than intermittent treatment. But I would put forth the concept that I think there is enough of an expert consensus to say that prophylaxis is so much better than intermittent treatment for all the reasons that we just said. So when patients have those 2 infections in 6 months, rather than waiting and seeing, let's see if they get another one, or let's wait till their 15th infection to think about prophylaxis. Prophylaxis needs to come way up in our discussion. And so rather than thinking so much about what antibiotic do I give this time, you want to go back and say, when was the last time I gave them antibiotics? And if it's been any time recently, we got to be thinking not just, I'm going to write this antibiotic prescription, but I'm going to write this antibiotic prescription and I'm going to get them a plan for prevention for the next one. And I think you can probably strongly tell if antibiotics are previously our sort of gold standard prophylaxis, I think there is enough data to show that we have non-antibiotic approaches at this point that are at least showing non-inferiority to antibiotics. And that if we can use these and get people better and let their immune systems work and let their natural microbiome recover, that to me sounds like the best approach. Although, doesn't work for everybody. And there are, antibiotic prophylaxis approaches as well. But the more that we can move towards this idea of the best thing for the patient is not just wait till they get an infection and treat them and empirically treat them with whatever I feel like that day. We can think about being more thoughtful, being more targeted, working more on prevention, working more on allowing those natural defenses to recover, will be so much better for our patients. They'll get better as opposed to just keep coming back. And the hope is that we can really improve the lives of women with recurrent UTIs with a much more thoughtful approach and much more careful consideration of those episodes.
Great. And, these are all important considerations, and effective antibiotic use is about balance in many ways, trying to achieve that symptom relief while preventing resistance and preserving the microbiome integrity. Well, with that, we're out of time. Dr. Ackerman, Dr. Kaufman, thank you for a very informative and obviously passionate discussion. Your insights provide a clear and practical framework for clinicians managing recurrent uncomplicated UTIs in women. For our listeners, this is an evolving area where evidence-based practice and patient-centered care intersect. To access additional educational materials, including the full AUA guideline on recurrent UTI, please visit auanet.org/university. I'm Dr. Mark Gonzalgo. Thank you for joining us on AUA University Podcast. Stay informed, stay engaged, and continue advancing the science and practice of urology.